Good morning, Sarah. How's it going?
Morning. Good. How you doing?
Good. It's fun to have you on the podcast. Just a ladies' podcast today. Very fun. Yeah, I've talked to you about this a little bit this week, but my body is wrecked. I did my marathon. I completed it. Woo, we did it. We did like 4.5 hours, which might not sound that impressive, but it was my first marathon. I'm very excited, and I'm just about able to walk downstairs now. Just
Hell
about.
yeah.
So we're getting there.
Which marathon was this?
It was the Maine Marathon in Portland, Maine, which is actually kind of a very small, just a very small sidebar. The same weekend, I believe, is the Portland Marathon of Portland, Oregon. And Kevin was signed up for the wrong one.
Was he allowed to run?
Yeah, he had to register, and apparently it happens enough that the Portland Marathon in Oregon does refunds very, very kindly of them. But yeah, that was a little bit of a snafu. But anyway, I will take us through this week's headlines or last week's headlines. And it's a really fun podcast today. It's Sarah's like second podcast or third podcast maybe, but it's her first podcast. Awesome. And she's going to be talking about her cover story. So it'll be a really fun, interesting conversation. So the cover story was about the very new advocacy organization called Patient Action for Cancer Research. It aims to show the impact of federal dollars, federal research on actual patient lives. And that's the one we'll be diving into today. So I won't talk about that too much at this point. The rest of the issue was really strong. Claire really, like always, Claire was an amazing quarterback. We had a follow-up story about the new NCI director, Anthony Latai. He was actually sworn in last week, so we were able to write about that and have a little bit more details about the cancer groups or health groups talking about his appointment. We also had a story about the government shutdown, which, a little bit of mystery, but we were able to do some reporting and got some information about how it's going to impact, or how it is currently impacting oncology. And then we had two incredible guest editorials. One was talking about the sexual and gender minoritized patients and how that they are being impacted by everything, all of the policy changes coming out of Washington and just the rhetoric right now. And there was a really strong, patient example in that story as well. So it fit into the issue really beautifully, and it kind of came together to prove the point once again that patients are, really should be at the center here. And then we had another guest editorial about the opportunities in community oncology in NCORP centers. So that's a really fun story. Definitely check that out. And then we had some cancer policies and in brief, but that's where I will stop. And today we have a guest from the board of PACR, the group from the lead story, Laurie McGinley. She is an award-winning journalist who covered cancer research, healthcare policy, and FDA for the Washington Post. And she is a former health and science editor at the Post and worked also for the Wall Street Journal, where she was part of a team that was awarded the Pulitzer Prize for reporting on AIDS. So very exciting. Just, I think, as we're journalists, I think we're excited to talk to her in general, and also really excited to talk about PACR. So welcome, Laurie. It's so good to have you on the podcast.
Thank you so much. I'm really excited to be on the ladies podcast. This is great, and to meet both of you. So thank you very much. Thanks so much for having me. Appreciate it.
Yeah, I love it. Well, Sarah, I'll probably let you talk to Laurie mostly, but I just have one question to start, if it's all right. I'd love to hear just how you got involved with PACR. I think I'll just end there. I'd love to hear how you got involved.
So I guess the answer is both because of my professional experience, but also personal experience. Peter Garrett, who, as you know, was the head of external relations at the National Cancer Institute. I've known him for 30 years through various jobs that he had in healthcare, communications, and policy. And we've worked together on various stories. So when he told me that he was leaving NCI and that he had this idea, I was like, wow, that sounds great. Anything I can do to help. So that's how I got involved. And from a professional standpoint, and I guess this takes us into the wider discussion, it's just so obvious that it's important to have patients and patient stories at the center of this debate, this very difficult debate that's going on now about funding research of all different kinds, especially cancer research. And this is not news to anyone in journalism or anyone in the cancer community. We're not trying to preach to the choir, and people already know this. But we're just trying to make it a little somewhat easier and to augment efforts to do this.
You mentioned that it was like somewhat obvious, but when Peter came to you, was there anything specific about the pitch, specific about PACR's mission and its approach that specifically attracted you to want to join the board?
You know, I just remembered this right now. So thank you for the question. One of the things that he said to me was that he was thinking about the days of the AIDS epidemic and his involvement in that, and how the advocates and activists effectively used patients and patient stories to make an impact on that. And that kind of really struck home, because when I was at the Wall Street Journal, we did a lot of coverage of AIDS, and part of it was it was the Wall Street Journal. So part of it was from a business standpoint, because Merck was racing ahead and developing these AIDS drugs. But obviously the stories that we were trying to do was about the impact on the patient. So we relied heavily on patient stories for those stories. So maybe that was part of the hook. And then part of the hook was just that I had done a fair amount of cancer reporting when I was at the Post.
Honestly, this is probably a question for maybe both of you. I think, this was also a landmark story for me as well. It was my first first cover story that I was a solo editor on. So it was big for me too. And I think when I was editing, I was struck by, as Sara and I were trying to write this story, right? We were trying to really dive into, tracing actually how federal dollars did impact our main character, Chris Bigger. It was really hard. It's not easy to actually, trace these dollars, because it's so much is basic science that goes back, decades. And you have to really be an expert in science to understand how all of those things connect. And then there's also, we've had all the conversations about indirect costs and, supportive structures, the fact that academic cancer centers exist. There's all of these things that come together to produce, I don't want to quite say cures. I mean, occasionally cures, but you know what I mean? Really effective treatments. And so I just wanted to talk about that a little bit, about how PACR, it's a big undertaking, but it's really important. And I think one of the quotes that Peter gave really drove this home for me was, people are failing to make that final connection of, actually how these dollars are being connected to patient stories. This is sort of a question for either of you. I mean, Sara, you wrote the story, and Laurie, you're in the heat of it. Just talking about that a little bit.
I'm very curious in what your answer is after, years of healthcare reporting, and whether you've kind of run into these challenges. But we had a main patient share his story, Chris Bigger. He was diagnosed with stage 4 metastatic colon cancer when he was at the age of 34. And it was a very, very chaotic period of time of his life. He had just moved to a new state. He had acquired his dream job. He'd lived in Ohio his whole life, and he was like, okay, I'm going to finally try something new, go on an adventure, move to North Carolina. And then within just a couple of months, he gets this massive diagnosis, and it totally upends his life. Actually relatively quickly, I think within the span of a year or two, he was actually able to become cancer-free, in large part because of immunotherapy. He had MSI high, a specific type of mutation that made him a very good candidate for nivolumab. And I never know how to say this, so I'm just going to say it the way that everybody has told me how to say it, but they just abbreviate it and call it IPI, so nivolumab and IPI. I'm not even going to try the full name.
It is a tough one.
And so I had this information about, the drug that he was on. I had this information about his particular diagnosis. And how do I kind of take this final human story and connect it to the whole history I mean, some of it's more recent because nivolumab and IPI was just approved by the FDA this year for metastatic colon cancer with MSI high or MMR deficiency mutation. So this is like brand spanking new, but obviously, cures don't happen, or like effective treatments, as Jacquelyn said, don't happen overnight. So how do I kind of reverse engineer and figure out what kind of led up to this, pretty much life-saving treatment for Chris Bigger? And we took one step back and we learned about, specifically identifying this mutation and its connection to effective immunotherapies. And that, in some ways, the mutation is more important than specifically, where the cancer is and what tissue the cancer is affecting in the body. So this kind of tissue agnostic discovery happened relatively recently, with some folks at Johns Hopkins University. There were other collaborators too, but Johns Hopkins led the study, with Deng Lei and also Luis Diaz. And, that was pretty integral into what Chris Bigger really benefited from. But if you even take it a step further, there's decades before that, including, what Jim Allison discovered. There were so many names that came up, but we really tried to kind of condense it as much as possible in the story. But a lot of the process was just asking people, do you know where the funding came from? Do you know what are the kind of seminal papers? What were like the big discoveries along the way? And people were just very vague about it. I think they understand certain names, they understand certain labs, but to be like this specific paper, it's hard to pin down. And so it took a lot of kind of trial and error, talking to a lot of people, and it doesn't sound like the specifics. I think the general ideas are often understood, but the specific grant number or the specific grant name was really hard to track down. And I'm wondering, Laurie, have you encountered anything like that?
Well, I'm so interested that you talk about this because I love the story, in part because you went back you kept asking, how do you connect this? How do you connect it? Which is something that we've talked a lot in PACR meetings and how important it is. I think the very, the short answer is you have to keep asking the question. You have to keep going another layer deeper to try to get the answer and keep calling. And I think maybe part of that's hard for reporters who are on deadlines, and it's, or for people on the Hill to find where are all these links? It can take, you probably found out, days and days and days, if not longer, to find out. So I do think that we might be able to help reporters do that because of, the great knowledge of some of the people who are involved in it. Ned Sharpless, former NCI, on the board and all that. So that would be one of the goals, would be to help. I'm not minimizing it. It's not easy. It won't be easy for us. It isn't easy for reporters. It isn't easy for congressional aides or anything. But I also love the story because I also wrote about that drug and about that particular genetic mutation, and about a young woman who was going to, basically she was 23 or 24 and she had stage 4 colon cancer and she was going to die. And she was basically dismissed by another very major cancer center whose name I will not mention. And her sister found a study somewhere that showed that Johns Hopkins was working on that particular problem in a clinical trial. She got into the clinical trial. Her name is Stephanie Joho, and she survived, and she's fine now. And it's just amazing. So, but I have to say, I don't think in that story I linked it to NCI funding. I think I focused mostly on what was happening at Johns Hopkins. And then separately in other stories, I talked about Jim Allison, who was the great pioneer of immunotherapy and checkpoint inhibitors. And I wrote about him, and I wrote about his, rock band and rockabilly band and all his discoveries and his awards and everything. I'm not sure, I don't know, maybe I mentioned that he got NCI funding. I'm not even sure that I did or not. So this is bad on me, and it's kind of interesting when I look back on it. I'm not sure that I made the connections when I was working as a reporter, and maybe it didn't matter because NCI funding was going up.
Yeah.
But maybe it actually matters now because there's such a debate about how we're going to spend money or how we're going to dole out funding and how many grants we're going to do now and how many grants. Whether we're going to pay them all up front or pay them partially. And every single policy and funding decision has an impact on the number of grants that go out. So yeah, I think it's hard. I don't think I did it very well. I mean, I did okay as a reporter, but I don't think I did that particular thing particularly well.
Well, I think you really touched on something because, as we were reporting it, Dung Lei did receive a lot of funding from philanthropic donations. There is an ecosystem of funding here, and I think, like you said, like it really wasn't something that we had to focus on as reporters prior to this year. I mean, of course, there's been ups and downs with NCI funding, but cancer has always been bipartisan. It's always been very well funded. It's always like there was the cancer moonshot. And of course, I'm coming into this relatively recently, but it's never been like a question. It's because everybody's affected by cancer. It's always been this sort of like, yes, of course we're going to fund it. And I think you're so right that is we were really kind of taking it for granted that it was, of course, the government's going to fund oncology. Like, why wouldn't they? And I think that to be fair, I do think that Congress has signaled that they are continuing to support oncology, but it's just getting swept up. And I'm kind of quoting Peter here as well, but it's getting swept up in all of the broader and the broader debates about science funding and biomedical research funding and all of that messiness and hopefully it will be fine. We have to see what happens. But, I do think that is just reminding people that, federal funding does make this all possible because, Dung Lei, the primary funding was through philanthropic donations for that trial. But like we said in the story, it couldn't have happened not at an academic cancer center. The academic cancer center, I mean, maybe they could figure it out, I'm sure, but they rely primarily or heavily, on federal funding. The body of work, the basic science that led to Dung Lei and her researchers or her colleagues' hypothesis was based mostly on basic science, often funded by NCI. And take Jim Allison just as an example. Do you have this, Sarah? The sentence? This was like
I'm looking it up right now.
It was so good. It was so good.
So even though Dung Lei, her research was mostly funded by philanthropy, Jim Allison had a lot of money from the NIH and NCI. Can I pull this up? In the story, we write that his research was funded, received $13.7 million from NCI and NIAID, and he received that funding since 1979.
Yeah, he's been continuously funded, which makes sense. Nobel Prize winner, of course, but it's just, and I think that's what's so interesting about you talking about covering that is like before that was kind of like, yeah, of course. And now it's like, wait, no, we need to really hone in on that, You
can't take it for granted anymore. And you're right. It looks as though Congress is going to at least maybe do flat funding. But the problem is nothing is certain. The only thing that is certain is that nothing is certain right now in Washington. And the White House has said that it does not have to spend appropriated funds. They've made that argument. So you have that. And then as we discussed and you have discussed the policy changes in terms of how the funding and it's not that things might not need to be changed or reformed or improved in the funding mechanism. I have no idea whether full funding of many grants upfront is a good idea or a bad idea from a budget standpoint. Maybe it is. I don't know. I just know that based on what I've read in the Cancer Letter and also in the Washington Post by my former colleague, Carolyn Johnson, it's just reducing the amount of grants that are going to go out this year by hundreds.
Yeah. The pay line is like 4% this year, which is, I've never heard of anything that low. It's a historic low. And it is largely because of that. They got the news in, I think, July that they have to do, what is it? I have to remember the specifics, but I think it's 50% of the grants this year have to be funded, like, funded for the full 5 years this year. And there's limited money. You can't do 5 years and also do 1 year for as many as we wanted to before that news.
Can't spread it around as
Exactly.
much.
Exactly. So yeah, definitely. And I think that's a good point as well. Like, Congress might support support, like you said, flat funding in a normal year would be terrible news, So this is, our metric has changed a little bit, but like the policy changes are also having an impact as well. So absolutely. Laurie, I would love to hear what you're looking forward to with PACR, what's on the horizon for you guys.
What I'm really excited about is actually because I enjoyed it as a reporter, so I think this would be fun, is working with different partnerships and different groups and seeing if we can work with the cancer centers and some advocacy groups and build some partnerships, not to take away any credit from them. We're happy to try to highlight for everyone how much what they're doing to take care of health patients, but to try to maybe streamline the process a little bit to make some connections between journalists and patients. And so I'm excited about that. And, the website also, which if I can put in a plug for the website, which is www.action4cancer.org. That's where patients can go and hit a button and tell us their stories. And then we basically have these wonderful volunteers who are calling them up and interviewing them and finding out whether the stories seem to be appropriate and whether there might be any journalists who are interested in it. So we're at the very beginning of this, so give us time. But I'm excited that might really blossom into something helpful.
One question I do have is, we've talked about making that final connection and that being kind of like a central tenet of PACR, and then also trying to help journalists find patients. I mean, I know from firsthand experience that sometimes that's the hardest part of the story. All of the technical information you can call somebody up and they can explain it to you, but trying to find a real person who is willing to share their own personal story. And obviously when it comes to being a cancer patient or a cancer survivor, this is one of the most vulnerable periods of their life, and they're just volunteering to share it with everybody. I'm wondering, like, in your experience as a journalist, have you run into any issues with that? And I don't know if you've talked to any of the PACR patients so far, but, has there been a reluctance at all in terms of being public about their story, or has it been more of a cathartic experience for them?
That's a really good question, and I would say both. Both as a reporter, of course, patient stories, as you know, can either make or break a story. It's one thing if you're writing about a study, New England Journal of Medicine study, where you're just doing a fast, hard news hit on something. But if you're doing something that you're trying to get substantial space in the publication or whatever, you have to have, for a general interest publication, you have to have a patient story. And I've had really good stories just die because I don't have a good anecdote or narrative or whatever, because the patients have all kinds of reactions to it. Some of it really do feel great, get great gratification and relief in telling their stories, but others are very private, and you can 100% understand that. And I've gotten way down the road with cancer patients who at the last minute have decided not to be in the story. And I'm always like, totally fine. It's totally up to you. And I think that the volunteers who are talking to looking for patients and talking to them they're running into the same thing. Some people are very excited about the process and happy to, this is kind of an easy outlet for them if they can, figure out how to access it. But others either don't want to talk about it, or they don't want to tell their story publicly, or they don't want to give us a picture or things like that. And I understand that completely. And that, of course, is not limited to cancer patients. That can be because, I've had that happen with people who have Alzheimer's. I've even had it with people who have high cholesterol, don't want to talk about it because they're afraid they'll be discriminated against at work or something. So you have to be very careful and make sure that they understand what the purpose is and how it might be used, so there isn't any upset at the end.
Well, thank you. It has been really
Thank
a joy to talk with you. Like we've said, just even as a journalist, just picking your brain has been a really fun time. So thank you. And yeah.
Thank you. Thank you so much. Really appreciate it.